Hello, my name's Dr. Dominic Chillen. I'm one of the F1s on Old Age Psychiatry at Leicester Partnership NHS Trust, and I'm going to give a quick lecture on schizophrenia. In this lecture I hope to cover the epidemiology, the etiology, some theories behind schizophrenia, the clinical presentation we'd expect to see, some subtypes of schizophrenia, diagnosis, differentials, investigations and management, and finally we'll do a quick bit on prognosis. So schizophrenia is a psychotic illness in which individuals will lose touch with reality. It's characterised by two main symptoms: hallucinations and delusions. Now, hallucinations are a perception in the absence of a stimulus, and this can involve any sense, although we usually see auditory or visual hallucinations. Delusions can be defined as a fixed false belief which is held despite rational argument or evidence to the contrary. We have to remember that the delusions cannot be explained by the patient's cultural, religious or educational background also. The epidemiology. So an individual's lifetime risk of developing schizophrenia is about 1% or 1 in 100. Onset is usually between the ages of 15 and 45 years, with males affected earlier and generally with greater severity than females. There is, however, an equal sex preponderance, so the likelihood of a man and a woman developing schizophrenia is equal, although men are likely, as I said earlier, to be affected with more severity and be affected earlier than women. So etiology, this is complex and multifactorial, so we'll skim over this briefly, but it can be put into two main components: genetic and environmental. Speaking about genetic first, the lifetime risk increases from 1% to 10% for a first-degree relative, and nearly 50% for a child whose parents are both affected with schizophrenia. We can also see high concordance with monozygotic twins of about 40 to 50% and dizygotic twins of about 10 to 20%. So no one gene has been found to increase the risk. There are likely many susceptibility genes which may code for clusters of symptoms, as we'll go on to explain later. But we can see that there's a strong genetic component with schizophrenia. There's also environmental factors. So obstetric complications. Now we always ask patients if their birth was straightforward and normal or if there were any complications, and this is one of the reasons we do it. It's because there is a higher risk of schizophrenia and other disorders with obstetric complications. Substance misuse is also another factor, and these are things like amphetamines, cocaine, LSD, but also cannabis use, especially in the teenage years, has been shown to increase the risk of developing schizophrenia by up to about 6 times. Social disadvantage is also a risk factor. Interestingly, this is not correlated to the social status at birth, but the decline in social status, or the social status at time of presentation. So it does show that it's possibly the schizophrenia that causes someone to decline in their social status, rather than their social status being the cause of or a trigger of schizophrenia. Urban lifestyle also is a risk. Again, this may be due to drift of patients, schizophrenics, naturally to urban environments. All this could be due to increased stress with an urban lifestyle. With regards to migration, first and second generation immigrants have a 3 times increase in risk of developing schizophrenia. With regards to ethnicity, Black and African patients show a higher rate of developing schizophrenia. It's about 4 to 6 times the baseline. This isn't fully understood, and it's not explained by higher rates in their countries of origin. Expressed emotion. So what this means is close contact with overly involved and overly critical relatives can double the relapse rate of schizophrenia. But this doesn't cause schizophrenia per se. It's more to do with the relapse. So someone who's already been diagnosed with schizophrenia and they go into a family with high expressed emotions, they're more likely to relapse and develop schizophrenia again. Premorbid personality. Now, there are some personality disorders such as schizoid personality disorder or schizotypal disorder, and these predispose individuals to schizophrenia. And there's thought to maybe be a shared genetic bias between those disorders and schizophrenia. Adverse life experiences. So these are things like sexual or physical abuse in childhood or adulthood, and that can also increase the risk of schizophrenia. So now we'll look at some of the theories behind schizophrenia. First, we'll talk about neurodevelopmental theory. Some studies have shown that smaller, lighter brains with enlarged ventricles are found in schizophrenic patients. Schizophrenic patients are also likely to have a lower premorbid IQ and deficits in learning, memory, and executive function. Now, it's important to remember that initial abnormalities, whether genetic or early brain damage, may not be perceptible initially but will reveal themselves in time as the brain matures, which is the reasoning behind this neurodevelopmental theory, saying that you can get a presentation in early adulthood, as is typical with schizophrenia. The second theory is the neurotransmitter theory, which is probably the most commonly talked about theory. And central to this is the dopamine hypothesis. Now, what's said is that dopamine overactivity in the mesolimbic tracts and underactivity in the mesocortical tracts are found in schizophrenia. And actually, this is very sensible because our medications support this theory quite well. All known antipsychotics are dopamine antagonists, and we know that they all work better against the positive symptoms that we find in the mesolimbic tracts rather than the negative symptoms that we find in the mesocortical tracts. And dopaminergic agents such as amphetamines, cocaine, and L-DOPA can all induce psychosis, and all of these can be indistinguishable from schizophrenia itself. However, this is unfortunately not the whole story, otherwise all of our antipsychotics would cure all psychoses every time, which they don't. And so there are other neurotransmitters such as serotonergic overactivity and glutamate dysregulation that are likely to be also at play here, all feeding into this core neurotransmitter theory behind schizophrenia. There's also a psychological model, and these are cognitive models which suggest there may be deficits in thinking, for example jumping to conclusions without examining all of the evidence, which causes the delusions. And the fear of these patients becoming or being labelled as mad prompt defences against rationalising these thoughts. And this leads to then a delusional system of explaining away, for example, voices or visual hallucinations. So it's almost like a negative coping strategy. So now we'll look at the clinical picture, and we'll start with the acute phase. So typically, the acute phase is the most striking phase, with the positive features being more evident, although we can see some negative symptoms also. Now, positive symptoms are things that the patient has gained. It's the easiest way to remember them as being new things. So these are delusions, hallucinations, disturbed thoughts. And negative symptoms will be things that the patient has lost. So this may be a decrease in self-care, a withdrawal from social situations, and anhedonia. So we'll talk about the acute phase in a little bit more detail here. So the patient usually presents with delusions, and these are usually persecutory in nature. So these are patients feeling that other people are out to get them. Delusional perception and passivity are also significant delusions, and by delusional perception we mean seeing things that aren't there or coming to irrational conclusions. And passivity is feeling like you are being controlled by someone else, or feeling that someone else is controlling your body and controlling the way that you're moving. So hallucinations, they're often auditory, and we would find it more common to see second or third person auditory hallucinations or thought echo being particularly common in patients with schizophrenia in the acute phase. So second and third person hallucinations are quite self-explanatory. thought echo as well as self-explanatory. So it's, if you come up with a thought in your mind, you're hearing someone else saying that exact thought. Again, it's not a voice that you recognise, and it follows you the whole time. Disturbed thought, which can lead to muddled speech. So thought interference, this is where we talk about insertion, withdrawal and broadcasting of thought. So thought insertion is that you feel that other people are putting in thoughts, that your thoughts are not your own. Withdrawal is you feel that people are taking out thoughts. You're thinking about something and all of a sudden these thoughts have gone out of your head. And thought broadcasting is feeling that either certain people or everyone can hear everything that you're thinking. Thoughts can be so disturbed and speech so muddled so badly that it can progress into something called a word salad. Now, a word salad is a string of words that have no connection to each other. It sounds like a sentence, but it doesn't make any sense. We also find behavioural changes, and these can be things like social withdrawal, overactivity, or just bizarre behaviours. Always remember to get a collateral history from a patient with schizophrenia in the acute phase, as it may be quite difficult to know, one, what their pre-morbid personality was, or two, what all of these delusions are, because they may feel that you're persecuting them, and they may not trust you enough to divulge all of the information that you'd want to get. So having a family member or relative would be very useful. So in the chronic phase, this is after a few years and can occur if patients do not recover from their initial acute phase. This is characterised by mainly negative symptoms. So all of the positive delusions will have gone away, and a lot of the time the voices that the patient was hearing will go away, and this will reveal apathy, blunted affect, so blunted mood, anhedonia, not feeling like doing anything, social withdrawal, and poverty of thought and speech. Now, moving on to the subtypes of schizophrenia. Paranoid schizophrenia is the most common subtype and presents in very much the same way as I described in the earlier slide in the acute phase. Catatonic schizophrenia can be characterised mainly by psychomotor disturbance. You'd find patients in a stupor, which is a state of being immobile, mute and completely unresponsive, despite appearing to be conscious. So you'll see the patient's eyes being open, following around the room, but otherwise not moving at all. There will be periods of excitement, and these are extreme and apparently purposeless motor hyperactivity. So the patient may be running around the room. You'll find posturing. A patient may assume and maintain an inappropriate or bizarre position for an extended period of time. It can be up to hours. And rigidity, that's holding a rigid posture against efforts to be moved. So even if you try and move the patient's arm, for example, it's absolutely stiff in that location. You won't be able to move it. We may also see something called waxy flexibility, and that is where the patient's limbs have almost no resistance to being placed in any odd position, and they can be maintained in that odd position for unusually lengthy periods of time. We also see states of automatic obedience, so any instruction you give to the patient, they will follow that instruction. And sometimes also perseveration, and that's inappropriate repetition of words or movements again and again. Now, it's easy to underestimate catatonic schizophrenia. It seems quite benign by this description, but patients may and can die from a catatonic state. Hebephrenic schizophrenia is another subtype. This is characterised by disorganised and chaotic mood, behaviour and speech. The patient will have shallow or inappropriate affect, and the patient's delusions and hallucinations are less prominent than that with the typical paranoid schizophrenia. Simple is where you see negative features only in the absence or the complete absence of positive features. So you wouldn't see any of those delusions, hallucinations that I described before. You'd see the negative symptoms, the decrease in self-care, social withdrawal, and anhedonia more so. Probably quite difficult to distinguish this and depression. And then residual, so this is negative features only following the original onset of the acute phase of paranoid schizophrenia. So diagnosis of schizophrenia. So Snyder's first rank symptoms are good to know for medical school exams. However, they are not necessary for the diagnosis of schizophrenia and may actually be all completely absent in schizophrenia. And this is because a lot of these symptoms can also occur in other disorders. So it's not Schneider's first rank symptoms aren't specific to schizophrenia itself. The things that we do look for though is delusional perception, passivity, thought interference, and auditory hallucinations. These are the ones that are most commonly found in schizophrenia. However, we use something called the ICD-10 or the DSM manual in the United States, and that has clinical criteria for diagnosing any mental health condition. So the differentials, when someone comes in with schizophrenia or any other type of psychosis, we need to think about organic causes first and foremost. Are these drugs that are causing the symptoms? Is it dementia? Is it something that can go away? Is it delirium? Is it something as simple as a UTI? It could be epilepsy, especially temporal lobe epilepsy, or it may be a medication that we've prescribed to the patient. As mentioned earlier, some of the anti-Parkinsonian medications as they work on the dopaminergic pathways. This could actually be an acute psychotic episode. So this has the same presentation of schizophrenia but will resolve in months rather than continuing for a longer period of time. It may be a mood disorder. If your patient's depressed or manic, they can produce psychotic symptoms also. Psychotic depression, you may have nihilistic delusions. These are where you feel that your body's dying, you see death around you. And in mania, you can have delusions of grandeur. You may think that God might be talking to you. So there are all sorts of other things that we need to consider. Schizoaffective disorder, so this is if the psychosis and mood disturbance begin simultaneously. Now, it's very hard to pinpoint this a lot of the time for the reason that a psychotic illness can be quite depressing to the patient. If they have good insight and realise what's going on, they may start to have a lower mood, so it may be an effect of the psychosis rather than something that's combined with it. And then persistent delusional disorder. So this is if hallucinations are absent in the presence of strong persistent delusions. So we're not hearing any voices, not seeing any hallucinations, but we are constantly delusional. Schizotypal disorder is a lifelong eccentricity and abnormal thoughts with no definite symptoms. So this is more of a personality disorder rather than a full-blown schizophrenia. So moving on to investigations. Now, our investigations are aimed at excluding organic causes and assessing the general physical health of our patients prior to commencing treatment. So first of all, we would probably do a urine culture, and first of all a urine dip, looking for any signs of a urinary tract infection. Blood test, we do a full set because before commencing treatment we want to have a baseline set of bloods. However, things that can affect the mental state are electrolyte imbalances, thyroid, inflammation from infection, so we'll do a CRP, hyper or hypoglycemia. Tertiary syphilis can also cause psychotic illnesses. And we'd also like to do lipids prior to commencing any antipsychotic treatment, as a lot of the side effects have a lot of the medications have metabolic side effects. Imaging, we like to do a CT head to see if there's any mass lesion, and special tests, we like to do a urinary drug screen, having a look at if the patient has any drugs that they may not have told us about, and do an EEG to exclude epilepsy if that's one of our differentials. We can also do some functional tests, so these are things like ACE-3 tests, and I'd recommend looking up ACE-3 online, and this is effectively an extended mini mental state exam, using Beck's or Hamilton depression rating scales. We get an OT assessment, and they'll look at things like functional abilities, and they'll use things like LACLs for that, and then social and work assessments. So with regard to management, in psychiatry we're quite holistic and like to treat our patients using a biopsychosocial model of treatment. So first of all, we look at the antipsychotics, and we either choose a typical or an atypical antipsychotic. Now, dopamine antagonists are the mainstay of our treatment. As mentioned earlier, this helps more with the positive symptoms, more so than the negative symptoms. And atypical antipsychotics are more selective and have lower risks of extrapyramidal side effects. Patients can be treated with clozapine if treatment resistance is an issue. So this if we've tried two atypicals, or an atypical and a typical, for a significant period of time, we found no improvement. We also use psychological management such as CBT or cognitive behavioural therapy, family therapy and concordance therapy. And then we'd also need to look at social approaches, and this is aimed at addressing the patient's needs. These are housing, social activities and life skills, and this seems very holistic compared to hospital medicine. However, it's important that we do everything we can to reduce relapse rates, and by fixing all of the social issues, or as many social issues that we can in our patients' lives, we can ensure the lowest risk of relapse of their condition. Moving on to prognosis, this varies vastly between patients and is based on numerous factors. The relative mortality of schizophrenic patients is over 2 times the general population, and this is due to poor physical health and things like increased accidents, as patients with psychotic illnesses are more likely to take risks, and increased suicide rates, especially in males. And if we look at the table on the right, we can see that 65% of patients are liable to relapse or have ongoing symptoms. 25% will have a full recovery with no further symptoms again, and 10% will have ongoing disability due to their symptoms. That concludes the lecture. If there's any further questions, please leave them in the comment section below, and I hope to hear from you soon. Thank you.